Chest pain. It's one of the most common and most critical challenges you're ever going to face, whether you're on the ward or, in your final exams. The key to nailing it isn't just knowing a bunch of facts, it's having a reliable method. So in this explainer, we're going to break down a really systematic approach to clerking chest pain, all grounded in the principles of Hutchinson's clinical method. The goal is to help you build a clear and confident diagnosis every single time.
But before we jump in, a huge special thanks to Dr. Mohammed El-Nagi Mohammed. All the great stuff we're about to cover is built on the foundation of his work.
Okay, picture this. You're in your final OSCE. The clock is ticking, the examiner is watching you, and your patient looks at you and says, "I have chest pain." What's your first move? What's your system? Well, we're about to give you that system, step by step.
So here's our game plan. It's pretty clear. We'll start with the patient themselves. Then we'll really deconstruct the pain, build their context, and then move on to the physical exam and investigations. And finally, the big finish, synthesizing it all into a confident diagnosis.
All right, Section 1, laying the foundation. Your diagnostic reasoning doesn't start when you ask about the pain. It starts the second you meet the patient. Those first little demographic clues, they're not just details for a form. They are literally the starting point of your entire investigation.
These initial details immediately start to shape your thinking, right? You hear they're an older patient, your brain should be thinking about ischemic heart disease. A manual laborer, musculoskeletal strain is already on your list. Think of these not as simple facts, but as your very first diagnostic filters.
Okay, now we move to the absolute core of your investigation, deconstructing the pain. This is where you really put on your detective hat, because the pain itself holds the most important evidence you're going to find.
And this is the central principle from Hutchinson's, and it's so true. The most valuable information you are going to get comes from a detailed, structured analysis of the pain itself. Everything else you do just builds on this foundation.
This is your systematic framework. You have to ask about every single one of these. Was the onset sudden? That might suggest something vascular, like a pulmonary embolism. Or was it gradual, maybe more like ischemia? Does it radiate to the left arm, that classic sign of cardiac origin? Every single question systematically narrows down your list of possibilities.
Now, what's really interesting here is how this directly translates the patient's own words into clinical hypotheses. If they say tight or heavy, your mind should immediately jump to myocardial ischemia. If they say sharp, you're thinking more towards the pleura or the chest wall. Burning? That suggests an esophageal cause. You're basically mapping their experience right onto the anatomy.
Now, as you're gathering this history, your brain has to be constantly scanning for these red flags. Things like pain at rest or a sudden collapse. These signal a life-threatening emergency that needs immediate action. These are the details you absolutely cannot afford to miss.
Okay, so after deconstructing the pain, it's time to zoom out and build a complete picture of the patient. And that means diving into their past medical history, their medications, lifestyle, and of course, their family background.
A positive past medical history is a massive clue. I mean, if a patient has known hypertension, diabetes, and hyperlipidemia, the probability of ischemic chest pain just skyrockets. A history of a previous DVT or PE makes a recurrence a really strong possibility.
The social history gives you such vital context. A heavy smoking history? Well, that puts both ischemic heart disease and lung problems high on your list. And, so crucially, asking about recent long-haul travel or just being immobile is a key screening question for a pulmonary embolism. And hey, don't forget the family history. A history of heart attacks in close relatives, especially if it was at a young age, should make you consider inherited conditions, and it definitely raises your overall suspicion for a primary cardiac cause.
All right, you've gathered the story. Now it's time to find the objective proof. We move from history-taking to the hands-on physical examination, where you're going to search for the physical signs that either support or refute your working diagnoses.
This slide perfectly illustrates the two things you're really looking for. First, general signs of high acuity. Is the patient obviously unwell? Are they pale, sweating, hemodynamically unstable? And second, specific diagnostic clues. A pericardial rub points you straight to pericarditis. If you can actually reproduce the pain by pressing on the chest wall, well, musculoskeletal pain becomes a leading diagnosis. So, you've taken the history, you've done the exam, now you need the hard data to confirm your suspicions. This is the investigation phase. This is where you get the objective evidence to finalize your diagnosis.
Your choice of investigations has to be logical, right? At the bedside, an ECG is absolutely essential for looking for ischemic changes. In the lab,
Cardiac enzymes like troponin are the definitive test for myocardial damage, and a chest X-ray helps you evaluate for any major pulmonary causes. Each test is there to answer a very specific clinical question.
This is it, the final and, honestly, the most important step. You've gathered all the clues from the history, the exam, the labs. Now you have to bring it all together to present a clear, logical, and really well-supported final diagnosis.
And this right here is the exact logical flow that examiners want to see. You're showing them how you started with a patient's story. You supported it with physical findings. You confirmed it with objective data. And then you arrived at an undeniable final diagnosis. Each step just builds on the last one.
This is your goal. A single, powerful summary sentence that states the diagnosis, like acute myocardial infarction, and then concisely lists the key pieces of evidence from the history, the exam, and the investigations that support it. This just screams mastery of the clinical case.
So remember this, in your final exam, the examiner isn't just looking for the right answer. They are testing your process. Following a structured, systematic method like this is how you demonstrate clear clinical reasoning, and that's how you get a high-scoring performance.
So you've seen the framework. You have the tools to deconstruct the problem, gather the evidence, and synthesize a conclusion. The only question left is, when that patient is sitting in front of you, can you build the case?